my name is Ronnie Shure. I am the president of Healthcare for All Washington. I volunteer as president. Tonight, Robby Stern and Ann Watanabe will be here to motivate us to help save Medicare. Thanks for joining us. And you too can volunteer with Healthcare for All Washington. Please consider working or volunteering with our policy committee, our communications committee, fundraising committee, or outreach committee. Uh, and there's several ongoing opportunities. But we also welcome you if you'd like to join us for a specific project or two, or just to offer advice. In the Zoom chat, we are posting a link to our website. You can go there. You can find a button that says Get Involved, and that's a way to volunteer. You also can find a button that says Donate. And while you're on our website this evening, please consider making a donation if you're able. Every donation helps us move along a step closer on this pathway to universal health care. We've set a goal to raise $250 during our program tonight. So you can go into the chat at any time during this presentation and you can make a donation or you can volunteer. You can hit the Get Involved button. And later on, check out the resources on our website. We will add the presentation that we're giving tonight. It will be available there. And you can also find our legislative goals, our long-term vision and strategies to move along this pathway to your true universal healthcare system. I am participating in this Zoom meeting tonight from the lands of the Coast Salish people. Please take a minute to acknowledge the people in the lands where you are joining us from today. We acknowledge all the ancestral homelands and traditional territories of indigenous people who have been here since time immemorial. Unlike our current national leaders who are selling off our lands for profit and possible destruction, we respect the efforts to preserve our lands by the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. Storytelling is a gift that our Native American ancestors gave us to help us save the land. I'm reminded of our current American landscape, political landscape, by a series of Yiddish stories, which were about a fictional town of Chelm. The stories tell of leaders who are really fools, but they think they are really wise. Tonight, we are honored to have two community leaders who really are wise, and we want to use their wisdom to overcome the fools in Washington, D.C., who are leading our country right now. So let me bring up Robby and Ann on our Zoom screens, and I'll ask you to unmute. Looks like Robby, you've already done that. Thank you, thank you, thank you. Hi, Ann. Robby is like the model of social activism. He's an activist who has fulfilled all the roles that are needed for social activism. He's a citizen. He's a rebel. He's been an advocate and a great organizer. He was leader of Puget Sound Advocates for Retirement Action, Social Security Works Council, Coalition of Washington, and worked with the Washington State Labor Council when he was a younger man. Uh, and tonight he'll be talking about the work that he's been a part of, he and Ann have been a part of with other groups around the country. And then let me introduce Ann. Ann Watanabe is the co-chair of the Committee of Puget Sound Advocates for Retirement Action, the Committee for Race, Gender, and Equality. I don't think President Trump has sent you any messages to cease and desist from that yet. She is an attorney with a background in land use and environmental law, and she has formerly served as a hearing examiner for the city of Seattle and King County. She's a Seattle native, a third generation Japanese American, and an essential part of the work that we're going to talk about tonight, PSARA's work to achieve equity and social justice. So let me pass it over to the two of you.
Thank you, Ronnie, and thank you for inviting us to speak. I just want to do a brief introduction about PSARA. PSARA has been around in various iterations for 45 years. It is a multi-generational organization, primarily seniors, but significant numbers of people that are younger than 65. And we're a growing organization. We've seen pretty significant growth in just the last year. Um, what we stand for and what we fight for is the right of seniors to live their senior years with dignity, respect, and economic security. And at the same time, we also see ourselves playing a supporting role for other struggles that are going on, whether it be racial justice, environmental justice. We're very active in the work in the state government. We'll talk about that a little more. Um, we're an activist organization. We have an executive board of approximately 30 members. We have a C3 and a C4. The C3 publishes our newsletter, The Retiree Advocate. That has been the name of it for 45 years. The Retiree Advocate is now a 12-page monthly newsletter. We consider it the best non-award winning newsletter in the country. The C4 handles a lot of the advocacy work and in a variety of settings. This presentation is going to address one of our major policy objectives. And what we're talking about is significant. Just some quick statistics about Washington State. As of September 24th, there were 1,523,700 people on Medicare. That's the latest figures we have. We know that it has grown because of the growing number of the generation, the baby boomer generation that are becoming seniors. There are about 49% of the Washington people on Medicare are on Medicare Advantage. There are over 1.8 million Washington residents on Medicaid, what we call Apple Health. That's more than 1 in 4 residents in our state. And in 2023, there were 1,452,000 Washington residents on Social Security, 1,140,000 are seniors. So these are the programs that we play a primary role in fighting to preserve and expand. We just ask you to please hold your questions until the end. And now I'm going to turn it over to Ann.
Great. Thank you, Robby, and thanks everyone for patiently finding your way over here. So I'm going to begin sharing a PowerPoint presentation, which hopefully will appear. And as Robby mentioned, we'll try to deal with questions at the end. But again, the impetus here is to level the playing field, and you'll be hearing us using that phrase a lot tonight. And again, Robby just mentioned all the things that PSARA does, so I won't go through this. Just a reminder that we're speaking on behalf of PSARA rather than the Medicare Trust Fund or any other private corporate entities. So going into the origins of Medicare, which I suspect most of you know, we're heading into the 60th year of Medicare. 1965 it was created, and what a wonderful concept. It's a public health insurance system for seniors and the disabled. And as we all know, it was very difficult for people to get insurance when they were seniors or they were disabled. So it was a wonderful idea. So let me just adjust this a little bit. All right. So the original concept was fairness. It was the same for everyone who was a beneficiary. It didn't matter your race, your ethnicity, your income, your location. And the thing I didn't know until I started working on this project was that it was originally planned to be expanded to Americans of all ages, which I know, all the folks on this call, you have all worked very hard to make that a reality. So
No, Anne,
I'm
if
just,
you if you hit
yeah,
the slideshow button at the very top of your screen, you'll get a full screen
yeah, I
view.
have that, and for some reason it's not. Let me try something else here. Sorry, folks, this is just not the night for any of us to have things. Okay, let's try this. Let's try this. I don't know why it doesn't want to. Okay, I am gonna well, how bad is it? Here let me, I can get out of screen sharing and try this again. It is not wanting to pop into the screen, into the slideshow mode.
Let it go, Ann. It's
And,
good
and just
enough.
Is it, good enough for people to see? I
Yeah.
really don't.
actually, Anne, just below that button you just pushed when you open that window, there's another sub button. So if you could do that one more time, go to slideshow,
Okay, start.
and then you
I'm
see
doing
what just below that it says start slideshow.
right. And I've been clicking that from current slide.
But just
And
below that,
yeah, I'm, oh gosh. Okay, I don't know. It's just not wanting to move into slideshow mode. I don't know why. I think it might be because I wasn't in that mode when I started sharing. So if I go out of sharing, is it okay? Can people, work with what we've got
I
here?
think it's a very clear document.
Okay, great, great. Then let's just move on because we've got a lot of material. So, original Medicare, again, we know that it's simple, efficient, and it's fair. And now I'll turn it over to Robby.
So, next slide. In 1982, as we know, the Congress created Medicare Advantage. Uh, and well, they created the possibility of private plans to go into Medicare, and that led to Medicare Advantage. Go ahead, next slide. Now, the intention of creating Medicare Advantage was it was supposed to, and this was in the legislation, lower the cost of Medicare and improve the outcomes for patients. We're going to talk about whether that happened in this slideshow. Next slide. Well, so what we saw was the introduction into Medicare of practices that had not been there before. Under original Medicare, you could choose to go to any provider. Under Medicare Advantage, you had to choose limited networks, and in some of those cases, they were ghost networks. That is, the providers in the networks didn't exist. The other thing that did not happen and still doesn't happen with original Medicare was the frequent use of prior authorizations. And the prior authorizations, in many cases, are a way to increase profits for those insurers. They placed significant restrictions on on care, and we'll talk a little bit about that in some personal stories. And very importantly, they created administrative burdens for providers and the system. Next slide. Now, what we should understand at this point is that this private advantage system is now very large. It is a profit-driven system. It, in fact, has more than 50% of enrollees in it, and we got to figure out why that is. And it is threatening the financial viability of the entire Medicare system. Why? Because of significant overpayments. United Healthcare, the largest provider, is now the fourth largest corporation in the United States. And that has a lot to do with their Medicare Advantage line of business. You take it, Ann.
Okay, so here we go again, the uneven playing field of today. We have original Medicare, as we mentioned before. It's very fair and open. You choose your own provider. The Medicare benefits are accepted by most physicians and facilities. The medical decisions are being made primarily by the patient and their physician, and prior authorization is not usually required. So basically, the decisions are, your coverage is being largely driven by patient needs. So when we look over at the Medicare Advantage system, and it's like what we're dealing with private insurance for non-Medicare beneficiaries. The patients are restricted to a narrow and changing network. Some of you may have heard about, for example, Aetna last fall was having contract negotiations with Swedish, Pacific Medical, some major healthcare providers, and they were on the verge of saying everyone who has those healthcare providers has got to figure something out really quick because we're not going to do business with them anymore. Well, fortunately, they did achieve a contract, but it just was very stressful for a lot of folks I know who were dealing with having to suddenly reschedule surgeries or find new doctors. So, and then we have the other side of it, which is that the healthcare facilities, the doctors themselves, and this includes hospitals too, are starting to refuse to accept Medicare Advantage because it's just expensive and they don't want to be second guessed by someone in the insurance industry. The prior authorizations are being made in ways that aren't medically driven. So if you have, even AI is becoming a more prevalent tool. So why would anybody choose Medicare Advantage? Well, there are some problems. Original Medicare, there's a large deductible for if you are hospitalized. There's a 20% copay for outpatient care, and there's no limit on total out-of-pocket costs, except pharmacy was capped at $2,000 this last year. So in order to cover that 20%, you are generally faced with having to buy a Medigap insurance policy. You are also faced with buying another pharmacy plan to cover your drugs. You get no hearing, vision, or dental benefits from original Medicare. So that leads many people to want to go over to Medicare Advantage because these plans will say that they've got a cap on out-of-pocket expenses. The prescriptions are generally included, and many of them offer coverage for hearing, vision, and dental. It's limited in many cases, but they are an appealing upfront opportunity for people to get health care. So what does this mean when people are on MA plans? And I'm sure, again, many of you have had some experience or a familiarity with hearing from friends or family who have had difficulties. But these are just a few examples from our own folks in PSARA. We've had denials where the Medicare Advantage insurance company simply flat out denies care. So in this particular case, we're talking about a denial of coverage for someone at a skilled nursing facility. You have the change of networks. So we have a gentleman whose Advantage plan authorized the treatment of knee injury by a very well-known orthopedic surgeon at UW Medical Center. But just before the surgery, the Advantage company denied care because they had removed UW from its network, much to the dismay of a patient who had been planning this for many months, and then he had to undergo the delay of trying to find someone else. And then finally, yes, delays themselves. Here we have an example of a primary care provider needing to get insurance company authorization to send a patient to a dermatologist because there's a tiny bump. Perhaps it's cancer. We didn't know. So the insurance company delayed authorization for months, and ultimately the patient had to wait and find a treatment elsewhere. And he was told it was cancer, and he was told by the physicians, well, it's too bad you couldn't have come in here sooner. We could have dealt with it a lot easier. Well, that was the cost of the delay for that particular patient. Okay, and I think Robby, we're on to you.
Okay, so despite the significant disadvantages of Medicare Advantage, as of 2024, 54% of Medicare beneficiaries are in Medicare Advantage. And it's really important to try and understand why. Why is that happening? And next slide. Part of the reason is what we've talked about before. Original Medicare is imperfect. It's a lot more complicated. You got to shop. Not only when you're in Original Medicare, not only do you need to shop for a supplemental plan, but you need to shop for a pharmaceutical plan. There is no out-of-pocket maximum, so you take great risk if you don't purchase a supplemental plan. And in addition, you have to pay premiums for Part D. So Medicare beneficiaries at this point have basically three options. You can keep Original Medicare and do nothing else, not buy supplemental, not buy prescription drugs, and risk bankruptcy. You can leave Original Medicare and sign up for Advantage, or keep Original Medicare and purchase Medigap. Maybe. There are some restrictions to being able to purchase Medigap. Federal protections. So Medigap is private insurance. So federal protections in Medigap for people with pre-existing conditions end after 6 months in Medicare Part B or 12 months in Medicare Advantage. Medigap insurance was specifically excluded from the requirement to provide insurance regardless of pre-existing conditions. So for people that have been in Medicare Advantage for 12 months, with the exception of 4 states, New York, Connecticut, Maine, and Massachusetts, which has something called guaranteed issue, if you are in Medicare Advantage for more than 12 months, and if your Medicare Advantage plan continues. Now, we have people whose Medicare Advantage plans did not continue, and if that happens, if they stop selling in Washington, then you're free to go in and purchase supplemental insurance, go into Original Medicare, and purchase supplemental insurance with a guaranteed issue. But that's not how it is for most people. After 12 months, you may be trapped in Medicare Advantage because they can, the Advantage plans or the Advantage plans or the supplemental plans can require that you do a health questionnaire and deny coverage if they don't want to have you in it and they're not realizing they have the total ability to do that. And the sad thing is that few people realize that when they make the decision to go into Medicare Advantage, that they could very well get trapped in Medicare Advantage. Anne, you go ahead.
All right. So yeah, let's talk about those pre-existing conditions that we all thought maybe we would leave behind with Affordable Care Act. But in the Medicare Advantage system, as we know, there's that open enrollment period where if you are in your Medicare Advantage plan, maybe you say, well, okay, it's open enrollment time. I've been on this Advantage plan for a couple of years, but it's just not working for me. My doctors, my specialists that I want to see aren't in my network. So I want to switch back to Original Medicare. Well, you are going to be beyond the period of protection from pre-existing conditions by the time if you get beyond a year. You could switch back to Original Medicare, but you may not be able to purchase a Medigap insurance plan because the companies are allowed in Washington State. They can underwrite you, so they basically will decide we either can issue you a Medigap policy or we don't, and then you're facing 20% of who knows what if you have a very serious health situation on your hands. It could be quite catastrophic. So, we do not believe this is a fair choice, particularly if you start looking at what the insurance companies are doing, and they are overcharging. We've got research to show that it may be as much as 35% more than what we spend on people in Original Medicare. In 2022, PNHP was analyzing it and found that 140 billion in overcharges was occurring. There's been a more recent analysis of overcharging and that estimated 1.4 trillion over the next 10 years in overcharging. So the other problem is that the mix of these overcharges is considered a trade secret. So it's not disclosed. We don't know how much of those charges are being spent on profit, overhead. But we do know that having all this extra money taken out of the Medicare Trust Fund allows the companies to offer those really attractive low monthly costs and out-of-pocket caps, and maybe they offer you, pet care and free food or whatever. So that makes those plans seem more attractive. So what we are also focusing on is how these public funds are getting used to profit private industry. Where have you heard this before, right? So again, we have Original Medicare, federally administered, low overhead. It's equitably funded through payroll taxes. The top priority is health, and it stays out of the healthcare decisions being made between a patient and their physician. We turn over to the insurance model, which is administered by corporations. There's a 15% overhead and profits. It's costing the trust fund more. You see 35% more per person than Original Medicare. Obviously, it's run by a corporation. Their priority is to maximize investor profits. That's why they're in business. And so we have the way they can do that is to delay, deny, and redirect the care because they have to continue to work on their profit margin. So this was interesting. I didn't realize this until we started doing this research, but the commissions given to brokers for promoting Medicare Advantage plans versus other plans, you can see an initial sale of a Medicare Advantage plan, 626. I think this is data actually very recent. And whereas a Medigap plan, along with original Medicare, their commission is substantially lower. Part D commission is low. And then for the renewals, you can see there's a big difference in the financial incentives offered to an insurance broker who, is selling or advising people on which plan they should go for. And let's see. So that kind of circles back around to where we end up in terms of racial and income disparities with Medicare Advantage plans. There really is no choice for many low-income or moderate-income populations. They want that low premium. They cannot afford to purchase a supplemental Medigap plan. So you can see here, this was from 2023 data breaking down the percentage of Medicare beneficiaries in Advantage plans, and you can see it's substantially higher for people of color. And you can also see that with regard to income, people who are low income, less than 25,000 per household, they're much more apt to turn to a Medicare Advantage plan. It is, the only option available to them up front. So, and now I will turn this back over to Robby.
So the corporations are actually pushing the notion that they are relieving inequities, but the facts really indicate just the opposite. What we see is a higher percentage of low-income people and people of color in Medicare Advantage. People with more financial resources tend to choose original Medicare. And the Medicare Advantage narrow networks are particularly harmful in rural communities. So Medicare Advantage was created to save money and improve care. And these corporations aren't doing what they were paid to do. We should not be paying. And one of the things that they're notorious for, by the way, is upcoding. They're paid on a capitated fee basis based on risk assessment. So what they do is they upcode and they ascribe certain illnesses to people they're covering so they can get higher capitated fee. That's one of the ways, an important way, that they achieve the kind of mass profits that they're making off the system. So at this point, it's clear it's not really a fair choice. We have members who are in Medicare Advantage who like their plans. And what we say to our members, and when we go out and speak in the public, if you like your Medicare Advantage plan, there are many people in Kaiser who really like it. We're happy for you and we want you to. But if you are in Medicare Advantage and you would like to be able to move into original Medicare and you can't do it, and new people coming in who are lower moderate income, and you can't do it, we think that we should create a fair choice. So how do we propose to do that? We say that the way to do that is level the playing field in Medicare. add the missing benefits into original Medicare, hearing, vision, dental, and pharmacy benefits, and limit copays and deductibles to more than $1,000 per year. At that rate, people would not have to purchase supplemental insurance, and they would be able to make a fair choice in terms of whether they want to be covered by Medicare Advantage or Medicare. PSARA is working with national organizations and groups and congressional representatives and senators who support that concept to reclaim the Medicare system to benefit seniors and the disabled, not private insurance companies. We don't want to have Medicare Advantage for all. We want Medicare for all. But if the trend continues with Medicare Advantage growing more and more because income inequality is growing more and more, once we get to the point of where Medicare Advantage says we got so many, we should just make Medicare Advantage what it is. We should make it now the choice for everyone. And in fact, it is understood that the Trump administration is planning to run a demonstration project where people are not given a choice and they're just moved into Medicare Advantage, and they're doing it through CMMI, the Center for Medicare, Medicaid Innovation, and the Congress has no ability to stop it. So what do? You ask your government representatives to strengthen and protect Medicare by creating a level playing field between original Medicare and the private Advantage system. And in addition, we are running a Senate joint memorial in the state legislature this year. Currently, before the Washington State House, it has passed out of the Senate on a party line vote. And that would put the Washington State Legislature on record as supporting leveling the playing field. And that in turn will be sent to our entire congressional delegation and to CMS, and it will then become a model for other states to do the same. Anne?
Okay, well, I think that brings us to just about the end of our presentation. So just leaving everyone with the very wise thoughts of Dr. Martin Luther King Jr. And at this point, I want to thank people for being such a good audience with with all the little glitches that are here. So at this point, I guess we can see if there are any questions.
Yeah, so Anne, if you can stop sharing.
Yes, I will stop sharing.
And Ron will make me appear and let you all take a back seat for a few minutes. But if you will add your questions, if you have a question for Robby and Anne, please add it to the chat. There will be an opportunity to respond to those questions in just a moment. I wanted to take a few minutes to make a pitch to ask you to donate to Healthcare for All Washington. Medicare is the gold standard. Robby and Ann are talking about a system that's been around since 1965 or prior to that, has been working and is the gold standard that we're trying to expand. There are certainly legislations nationally and statewide to improve that. So Healthcare for All Washington is trying to move along the pathway to reach universal health care for everyone. We do have expenses of a staff to maintain our information on our website and to get out, hopefully, the correct links to join us. And we do have a lobbyist who connects us not just with legislators who are in the Washington State House or Senate, but also with the agencies, the Healthcare Authority and Department of Health and Office of the Insurance Commissioner that actually have to implement what the legislators say. This lobbyist really is making a difference to help us get our foot in the door and help push and make that implementation happening. So if you are able to make a donation, please go to that link that Ron is putting in the chat, and you can uh, make a donation at this point, and you can also look at our opportunity to get involved and to volunteer to join one of the ongoing committees, or let us know if you have some ideas that we can integrate into the programs that we are doing. So again, thank you for for joining us tonight, for taking your time to come in here. We're sorry to put a barrier in the way, uh, but uh, let's bring back Robby and Ann. Uh, there is a question in the chat about one of the programs that Medicare provides is in addition to coverage for seniors, there is coverage for people with disabilities. Someone has asked about the problems of finding that particular coverage. Uh, can either of you speak to the issue of the difference between Medicare's coverage for people with disabilities and Medicare's coverage for people over 65?
I personally can't. I'm surprised. I read Sherry's comment, and I mean, my thought was I was not aware that there is a different standard applied to people with disabilities coming onto Medicare, and it suggests that there is. I know that for people coming onto original Medicare, you absolutely have the right, guaranteed issue of supplemental insurance if you originally choose original Medicare. Um, and you continue to have that right through 12 months if you switch during that period. But if you stay in for more than 12 months, then you don't have guaranteed issue anymore. I was not aware that there wasn't a similar guaranteed issue provision for people with disabilities. So that was a surprise to me. Um, I'm glad that Sherry found something that was working for her. And I hope that her Medicare Advantage plan continues to work for her.
And one of the things that PSARA, that Robby and Ann are working on, is to help people identify that coverage. There are counselors that are educated and led through the Office of the Insurance Commissioner in our state. And PSARA has spoken with the Insurance Commissioner recently about the fact that they are building that program and making those counselors available. There's certainly not a perfect solution, but the program is called Sheba. Uh, Robby, can you address that source?
Yeah, well, it stands for State Health Insurance uh, Advisor. Let's see, State Health Insurance Benefit Advisors. And yes, it's run, they are all mainly volunteers who are trained by the Office of the Insurance Commissioner, and they really, really know their ins and outs about the current regulations and rules. So they're a great resource.
And Sherry, it looks like you've added another comment about current legislation that's in place. Washington State uh, does allow people to receive Medicaid if they are, also qualify for Medicare, but we have the highest percentage of reaching the poverty level are one of the highest in the entire country. And one of the things that all of our healthcare advocacy groups have been working on is to address that discrepancy. There was a study that was financed in the 2024 legislative session to address that high percentage and to educate the staff or let the state know what it would cost to really change that uh, requirement. So that's what is happening.
Well, there was legislation that was introduced in 2025 to make Washington a guaranteed issue state, like those four other states that I mentioned. Um, Previously, I don't know if this is the study you're referring to, Ronnie, but the Milliman was hired after we passed a budget proviso to study what would be the consequences of making Washington a guaranteed issue state. And Milliman came back with the study saying that it would increase the premiums for supplemental insurance significantly if they did that. Now, there were many of us that questioned that study because we looked at what the premiums were in states like Connecticut, New York, Maine, and Massachusetts. And in some states, they were higher. In some states, they were lower than what the costs were for supplemental insurance here in Washington. Um, we went in and testified. The Office of the Insurance Commissioner did as well. At this point, it's not clear. Well, it's clear that legislation is not going anywhere in this session. Whether it's going to move in 2026, it's hard to tell. There is the concern that it could price out people who are on original Medicare now and purchasing supplemental insurance. It could make supplemental insurance so expensive that they would not be able to remain in original Medicare. And we have members in PSARA who have those concerns, who are very modest income and are on original Medicare and are stretching to purchase supplemental insurance. And they have voiced concerns that if we became guaranteed issue, that could push up the cost of their supplemental insurance to where they could not afford to remain in original Medicare. That's the beauty of leveling the playing field, is that people actually could change and not have to worry about the cost of supplemental insurance. They could just purchase original Medicare, and that would be the end of it. It would be as simple as Medicare Advantage and better. From my perspective, that's the only way we're going to stop the privatization of Medicare. If we were to go in and try and eliminate Medicare Advantage altogether, we would have a lot of people who are happy on their Medicare Advantage plan, and Sherry has indicated that she's one of them, who would raise hell at the notion that we're going to get rid of Medicare Advantage. So instead, what we want to do is create something where people have a genuine choice, which they don't have now.
So you have been an active member of a national coalescence.
That's right.
Other states that
That's
are
right.
taking some actions. And I was wondering if you could share what value or actions are coming out of that and
Well,
what we can
I'm
look
really
forward to.
excited about that. I mean, no less a person than Wendell Potter said in a meeting that if we were to actually level the playing field, it would be the death knell of Medicare Advantage, which is really what we would like to see. Um, and we know that the campaign for single payer, that the labor campaign for single payer is doing a lot of educational work on leveling the playing field with unions and why it would be in the interest of unions to do that. The coalescence is working in a variety of areas. One is to expose the abuses of Medicare Advantage. And I see David McClanahan is here. And PNHP has done a terrific job of doing that. So we are in a national coalition that meets every 2 weeks. There's a lot of national organizations that attend. PSARA is one of the very few regional organizations that have been invited to attend because the notion of leveling the playing field grew out of our work when we were out and listening to people and hearing what they had to say. We realized that that was the road to go down. And I think we're seeing that message resonate. And I think it's really important to really give people a choice.
That work on a national level is so, so important. Can I bring you back to a state question, another question about state, which is Marcia has asked the information you provided here tonight, how can that be used by Sheba advocates? And we've had that discussion with the insurance commissioner about the limitations of what they can say and can't say. And can you just share with us the outcome of that conversation?
Ann and I attended several Sheba presentations. And talk about what you saw, and I'll talk about what I saw.
Yeah, they are limited to explaining what is actually happening, not the policy that we'd like to see. But Robby and I both attended the sessions that they hold during enrollment period. And, I know in my sessions, the volunteers were glad to give time to me to ask and make statements about what PSARA was working on, because people were very happy to know, including the volunteers, that with Sheba, that maybe there's a path forward. I mean, you think about those Sheba volunteer counselors, they are constantly talking to people who are stuck in an advantage life and are facing, they're stuck and there aren't any great answers for them right now.
Uh, the one that I attended was in Wallingford, and the Sheba guy was saying, I got to be neutral here. But then he laid out all the problems with Medicare Advantage. And he was being neutral. He was just saying what it was. And he too invited me to get up and talk about what we were doing. And we had a flyer that we made up that we took into Sheba presentations that we could hand out to people. So I think that they know what's going on and they try to be circumspect about it because they're told they have to be neutral. But in this case, it was really clear to me he was saying that. By the way, the one thing I didn't mention is that we didn't mention is the whole question of providers advising people to get out of Medicare Advantage. And the most recent was Fred Hutch. Fred Hutch sent out an email on my charts to all of their seniors who were on Medicare, advising them to get out of Medicare Advantage and to go into original Medicare if they could. And that is if they could afford it. And because the networks of most of the Medicare Advantage plans do not include Fred Hutch, which is the premier center of excellence for cancer in our region. So this is happening, and providers are now advising people to get out of Medicare Advantage. But we have to deal with the financial incentive of taking Medicare Advantage and the simplicity of it. And that's a barrier that we have to overcome.
Well, thank you, thank you, thank you. We would like to end. We usually start at 7 and end at 8. We started at 7:15. So for these last few minutes, let me just again thank you, Robby and Ann, for sharing some wise voices. There is so many fools talking about what should happen to us, what should happen to our Medicare. And it's something we want to build on in our state, and other states across the country are working to do that same. So thank you for sharing this information tonight, and for taking your time. Uh,
Ronnie, may I make just one plug?
sure.
If you want more information, there's a wonderful resource page at the PSARA website. It's PSARA.org. And if you want to get this Best Nine Award winning newsletter in the country delivered to your home or electronically, you can, at the same time, you go to PSARA.org, become a member for $20 a year and receive the newsletter. And we'd love to have any of you that are interested as members. Thank you for letting me make a plug, Ronnie.
And also adding to that, Robbie, there is a uh, combination or a coalition of all of the articles that have come out of that newsletter from PSARA, and there's a PDF that you can download onto your very own computer to read the articles that are specifically about Medicare and the problems with the insurance company's disadvantage or Medicare Advantage program. I Also, let me thank volunteers who helped make this happen. Sydney Jones, our communication person, Ron Lovell, Rich Legoo, and D.W. Clark, who are online with us right now, helping us do it. If you would like to volunteer for future events, let us know. On May 14th, our second Wednesday speaker series speaker will be Michael Fine, who's the president of another single payer organization, national organization called Primary Care for All Americans. Dr. Fine is the former director of the Rhode Island Department of Health, and he's been president of this organization, single payer organization, since 2023. He's currently the vice chair of a clinic, a board in a small community clinic, and he will be using that as an example of how democratic healthcare, or how healthcare is a part of our democracy, and how we can make that happen. Uh, and also uh, want to give you some homework. Uh, simply that uh, Dr. Fine is also written a couple of books, one called Healthcare Revolt, about organizing and building a healthcare system that will resuscitate democracy. He's like shares some really clear points that he's developed. A more recent book is about how medicine has become a lack of equity. And there also is a website for that single payer organization. It's called Primary Care, then the number 4 AAA. So PC4AAA. But join us next month to open up that conversation. So again, thank each of you for taking your time to join us tonight, and we will continue this conversation. These are the kind of things that motivate us all. So thank you again, Robbie and Ann. And good night, everyone.